Madam Chair and members, thank you so much for the opportunity to be here. We sincerely apologize. We were expecting only a brief meeting with the Speaker and the Leader, and they were very generous with their time, so we are sorry for our lateness in arriving here today. We recognize, Governor Rendell and all governors, the importance of small businesses. It is the main engine of our economy in Minnesota and across the nation. 70% or so of all the new jobs created in the country are created by these small and early stage companies. It is vital to our future economic picture and health in this country to make sure our small business sector is healthy. And a key variable, as you well know, Madam Chair and members, is the ability to contain health care costs for small businesses, not only as a way to help them provide health insurance coverage to their employees, but to allow them to even remain viable. I'm the governor of one of the, I think, best states from a health standpoint in the country. We have the healthiest state in the nation 7 years in a row. Vermont just beat us out this last year, so we're second this year, but we're going to get them back next year, Madam Chair. But for 7 years in a row, the healthiest state in the nation by a number of wide measurements on health. We have the second longest rate of living or longevity in the country, second only to Hawaii. I think they have us beat out on tropical fruit digestion and eating there, but that helps them. We have one of the lowest health care costs in the country, and as you mentioned, we have the lowest rate of uninsured in the country at about 7%. It fluctuates up and down a little bit. Many states define full insurance. In fact, Massachusetts, I think, is defining universal coverage at 95%. We're already at 93%, and we still have a ways to go with respect to our reforms. The reason I share all that with you is not to brag about Minnesota, but to tell you that even with all of that nation-leading status, home of the Mayo Clinic, home of the University of Minnesota, even with all of that, we can't make the current system work and have it be affordable and accessible and high quality the way it's currently configured. And so that's how high the bar has become for our citizens and for our small business leaders and job providers across the country. The costs of this healthcare system are killing us economically. The current system is not sustainable for individuals, for families, for small businesses, for local units of governments, for school districts, for counties, for state governments, for the federal government. It is the thing that is driving us further towards insolvency financially and economically, and we hope that you'll join us and I know you will, in trying to find ways to make it more affordable and available. We've seen in Minnesota, as the nation has seen, an erosion of employer-sponsored, employer-provided health care coverage. That's very concerning as that displacement occurs. Those individuals either are on their own or they fall through the cracks or look increasingly to government programs, and that has its own limitations and concerns associated with it as well. As to my comments that the current system is flawed and what we could do about it, Madam Chair, right now we have a system where what we pay for is not aligned with the outcomes that we desire. And we have a system where we pay for procedures, volumes of procedures, and is largely disassociated with whether those procedures are leading in an efficient and impactful manner to better health, or whether the health care being provided is of a high quality, and the pricing around that is quite mysterious to most consumers and even to some third-party payers of those bills. In short, and in oversimplified terms, we have a healthcare system where all of us get to go to a healthcare provider as consumers, consume goods and services, being largely ignorant of price or quality, and then we send the bill to a third-party payer, namely an insurance company, an HMO, or a government, and they pay the bill. There is no system that I'm aware of where that's going to work. It defies what we know about human nature. It defies what we know about markets. And all of the flaws and warts of that are now being visited upon us in terms of what we see in the deficiencies in this system. Madam Chair and members, if we invited you to go purchase a television, and I hope you'd purchase it at one of our great Minnesota companies like Target or Best Buy, headquartered in Minnesota, and we said no consideration about price or quality, just go pick out a television. I doubt that many members or citizens would go pick out a 12-inch television. I think probably most of the people would go get the big flat screen. And so we need to connect consumers and payers and providers as it relates to how we pay for the desired outcomes that we have. With that in mind, we note that even in Minnesota, with all of our nation-leading healthcare quality and delivery systems, until recently, only 1 in 10 people were getting optimal care in diabetes. We know what optimal care in diabetes is. We can define it at Mayo Clinic levels. We can define it at world-class leading levels. And 1 in 10 people were getting that kind of care. And if you don't get optimal care in diabetes, it leads to very expensive, worsening, problematic chronic conditions that get even more expensive. So paying for providers, as one example of many, to move their patient loads towards optimal care and putting benchmarks around that and paying premiums, paying incentives for that, seems to me like it makes a lot of sense. And you know, most of the money goes into the 5 big chronic conditions. It's diabetes, obesity, heart disease, cardiac care, end-of-life issues, and you know, setting best-of-class expectations on quality and paying for that rather than paying for volumes of procedures seems like a movement that we need to take with respect to our payment systems. I also think there's a lot of backroom costs that can be taken out, and we're requiring in Minnesota in our public health programs, if you want to be paid by the state government and be a participating provider in our state programs, you got to e-prescribe. Now there's some legacy problems with that in terms of small providers and rural providers who can't make the pivot. We're going to try to give them some financial help, but at a time certain in the next couple of years, if you want to get in to be part of a provider in our state program, you got to e-prescribe. We have a nonprofit that's been assembled of our healthcare providers in Minnesota that will share medical records electronically. That's not a government central storage of data. It's the ability for providers to mutually go into databases with proper security in place and pull out medical records. So if you're in Duluth, you can get the record from Minneapolis that you may need, even though you had 2 different providers. From an employer standpoint, Madam Chair and members, 125 plans are low-hanging fruit, you know, and they're not costly to set up for employers. It's a relatively modest and easy thing to do, but if they do that, whether the employer actually pays for the insurance or an individual comes to the marketplace and can declare the benefits of a 125 plan, it's a significant savings either for the employer and or the employee. So I would encourage that type of approach as well. But if and there are many other things, but if I were to leave you with one thought that I think is just critical, is we have to reform the payment system. Some would argue that the way to do that is to move to a single payer system. For me, I don't think that is the correct approach. I don't think it's realistic. I don't think it will work. For me, I think the idea is to get transparency around quality and price and be very aggressive about that. And the new reform that we have in Minnesota is to try to put to the side the third-party payers, the insurers, the health plans, and have them become vendors of the providers, but have the providers come forward and be the bidders of the price. They can name whatever price they want, but once they name it, it's good for a certain period of time, and it has to be available to the whole small business, whether it's the government. When we go to Minute Clinic, which was started in Minnesota, there's no mystery about what stuff costs. You know, go to the CVS up on the wall when you walk in. If you want the flu shot, there's the price. You know, if you want the strep test, there's the price. It's simple. So we need to have price transparency in ways that average Americans, average Minnesotans, average citizens of Governor Rendell's state can see in a user-friendly, simple format. And then I think we also have to align payments, whether they're coming from individuals or third-party payers, to quality, and not defined just by the volumes of the procedures. If you pay providers by how many procedures they're performed, you're going to get more procedures. If you pay people to keep people healthy and define what that means, either in terms of initially optimal care but ultimately outcomes, I think that's a better use of our money and a brighter future. So that's the direction we're headed in Minnesota. I would say it's mission critical for our country. This issue, as one measure, and you know this, at the rate that these programs are growing at the state level and candidly at the federal level, this will usurp the vast majority of our state's budget within 20 years, probably within 15 years. It has enormous implications for our ability to do almost everything else, K-12, higher ed, roads and bridges. It is the big vacuum in the room, and if we don't find a way to deal with this, it's not only going to be a very severe challenge to small businesses, but the rest of what we're trying to do as well. Thank you for listening. I'd be happy to answer your questions after Governor Rendell.